Welcome at this plenary WONCA session on COVID-19 with a special focus on treatment and diversity. My name is Patrick Bindels and I'm a professor of general practice at the Erasmus University in Rotterdam, the Netherlands. And I will be sharing this session together with Professor Maria van den Muijsenbergh, and she is a GP and a professor in health disparities and person-centered integrated primary care at the Radboud University in Nijmegen, the Netherlands. Well, SARS-CoV-2 and COVID-19 cause a pandemic. I'm probably not really surprised you with this information. The epidemic has an enormous impact on personnel, healthcare, patients, and its resources. Although in most, not all European countries, the number of new cases is at this moment declining and vaccination coverage is increasing, virus variants are still popping up and it's a little unknown what will happen in the coming months. But it will also not surprise you that COVID-19 is a topic at WONCA 2021. Primary care has had an important role in the management of SARS-CoV-2 and COVID-19. Well, therefore, in this plenary session, two distinguished presenters, Professor Chris Butler and Professor Yves, will update you on treatment interventions in early COVID-19 and the special impact COVID-19 had on migrants. Well, if during these presentations you do have questions, you can see this question bar in the screen where you can ask your questions, and we will try to ask these questions at the end of the presentation to both presenters. Now, let me start with introducing you Professor Butler, because it's an honor for me to introduce him, because Professor Butler is a professor of primary care at the University of Oxford. He's a clinical director of the primary care clinical trial units, and he's trained as a physician and a clinical epidemiologist. Well, his research focuses on common infections and more specific on the appropriate use of antibiotics and the treatments of viral infections. Well, he has led several important clinical trials in this field, including EU-funded multinational and multi-center trials. Well, knowing his research focus, it will not be a surprise for you that he's also leading the principal trial on interventions against early COVID-19 in primary care. And in his presentations, he will tell us more on the trial results, but also on a quite innovative trial design of the principal trial. Professor Chris Butler, let's put it this way, the screen is yours.
Right, Patrick, are you seeing that good? Yeah, good. Well, thank you so much for those kind words of introduction, Patrick, and I should also say thank you for all you've done to help research in primary care over many years, including on trials that we've worked on together. But great privilege to be here to talk about really innovation in trial design, innovation in trial delivery, and also in adding to the evidence base for managing SARS-CoV-2 in the community. And I'm going to talk today about the principal trial, which is a trial of community treatments, early treatment for the pandemic condition. Now, as Patrick mentioned, there's no room for complacency, despite the fantastic vaccination effort that's been going on, because therapeutics are still urgently needed. If we look at this, there are huge numbers of people still getting the illness and dying from it around the world, and that's the daily deaths worldwide that have been encountered on the 1st of July. A lot of people still dying. And in the UK, the daily cases are sometimes between 20 and 30,000 at the moment. So a lot of those are asymptomatic, but a lot of people are still getting quite sick with SARS-CoV-2 in the UK, despite the huge vaccination efforts. The issue of primary care trials is really important because most of the people who get SARS-CoV-2 are managed in the community, and this is where we can have the greatest reach and impact in the care of people with this condition. And people in hospital have done some amazing trials, but it's in primary care where, in a sense, if we find effective treatments, we can get people to regain their usual health status, get back to their usual activities, and we can, in a sense, prevent them from becoming eligible for the important hospital trials that, in a way, are running out of interventions to try. So we started with the goal of evaluating repurposed drugs, but we knew that new treatments would be coming down the line as we went forward. So we needed a trial design that was flexible enough to have treatments added in as you go along, because you couldn't set up a trial each time you had a treatment. That would be really inefficient if you had a bespoke trial per drug. And, you know, traditionally we've done trials. I was just thinking about one I did the other day, which from the moment of the idea, getting the trial to the publication took 10 years. And during the pandemic, that kind of approach wasn't going to be helpful. We needed rapid information about what didn't work and what worked, so it would be useful within the pandemic itself. So talking then about the trial design that could allow us to deliver answers about drug treatments of community COVID, I'm going to just sort of mention the idea of a platform trial, which is really a trial infrastructure where you have an overarching master protocol with intervention-specific appendices attached to the master protocol for each drug that you add in. And so the platform infrastructure allows new treatments to be added in as you go along. And each intervention-specific appendices gives you the specific inclusion and exclusion criteria, tells you about a particular drug. Now, in a principle, just to summarize the PICO, we started out with anybody over age 65 with a condition being eligible, or between 50 and 64, provided they had a comorbidity. But more recently, we've certain treatments, such as ivermectin and colchicine, which I'll come back to, we have included the eligibility age from 18 and above, provided people randomized to those conditions have shortness of breath or comorbidity. They shouldn't have been sick for more than 14 days, but they need to be not recovered and continuing to be sick. And the interesting comparison is not against placebo, but against usual care. And I'll say a bit more about that in a minute. There are two co-primary endpoints. The first is recovery within 28 days, time taken to feel completely recovered. And the second is whether people are admitted to hospital or die within a 28-day. And they're different populations. The platform trial design allows you to use controls that were in the trial even before a drug was introduced into the trial. So a drug we've introduced this year, for example, all the controls from the start of the trial give us information about that performance of that trial. And the response adaptive randomization is when the trial is analyzed continually. So it's not like a traditional two-arm trial where you wait till you've reached your sample size before you do the analysis. This is going on all the time. And as soon as you get a signal for futility, you can remove that drug. And as soon as you get a signal for superiority, you can announce that so it can impact upon care as soon as that figure is available. But we don't, we can analyze everybody in the trial, and then just those who've had a positive test and just those who've been randomized at the same time as the drug is in the trial. And I'll come back to that in a minute. The question that is often asked is, why is there no placebo in this trial? And a lot of people who've gone a weekend course of evidence-based medicine will have said something like, well, if there's no placebo, it's a bias study and not worth paper it's written on. But I'd like to remind people that in pragmatic research in primary care, when we as primary care clinicians are sitting in our practice, we want to answer the question, am I doing this person a service by prescribing the drug to them compared to if I didn't prescribe the drug to them? In primary care, we don't compare the benefits of a treatment to the benefits of a dummy treatment. We compare a treatment versus not giving them that treatment. And so that is scientifically the correct comparison if we want to know what would happen if we used this drug in the real world. Now, just to summarize some of the features of this novel trial design called a platform trial, you can see here that we have a control in black, and in this case, 3 drugs, A, B, and C. A, B, and C have started off at the same time as control, and we're going along here as normal in a 4-arm trial. But as the trial progresses, we can add in 2 more interventions, in this case, intervention D and E, and quite quickly we get a signal, because the analysis is going on all the time in the background against pre-specified criteria, that intervention C is futile, or maybe is even causing harm, so we drop that. Then we can combine interventions if needs be, perhaps say ivermectin or inhaled budesonide, and see the effects of 2 treatments together compared to them alone. And here we find a signal of superiority for intervention B, and that can then become part of the standard of care. So the control changes to whatever is best practice at the time. Results from the trial can impact upon that. That gives you a sense of flexibility of the master protocol approach. And I'm going to talk a little bit about some of the innovation we've introduced to trial delivery in the principal trial. And I'll just mention the inverse care law. Many GPs around will know of the work of Julian Tudor-Hart, who was a solo GP for many years in Glencorrig in the South Wales coalfield. And in the launch back in the day, he proposed this inverse care law, and it's worth reading the first paragraph, the first sentence. The availability of good medical care tends to vary inversely with the need for that in the population in which it is studied. And our inverse research participation law that I thought out is really says what common practice in primary care research, that we notice that access to research is often inversely proportional to a participant's potential contribution and to where the research findings should be of the most application. And we see this in COVID research. Lots of hospital-based studies, lots of ICU-based studies, and very few primary care trials. And traditionally, what we started off with was the sort of model of research being done at general practice or family doctor offices that are set up as sites. And very quickly, principal set up of 800 GP practices as sites. And no sooner had we done that, and look, there are 5,500, I think, in England alone. And so not all GPs wanted to, could be part of the trial, and it takes time to set them up. So a lot of patients were being excluded from participation because they weren't registered with the GP who was being part of the trial. And the government then told them to not see their GPs, but to go to hot hubs or use a national helpline called NHS 111. And so we developed a model which I might summarize as taking research to patient, where centrally patients could be referred to a website where they could register, or GPs could register them online that way. And then we could take online consent, so there's no paper involved. We could do the the eligibility check centrally, sometimes using a thing called a summary care record, or getting information from their GPs. And then we could courier medicine from our central trials unit directly to the patient's home. So they didn't have to leave their house. So they were sick people, infectious usually, They didn't have to leave their house at all to participate in the study. And we allowed them to have a study partner. So if they were too sick to answer the daily follow-up data or went into hospital, a trial partner could give us that information. And they could take swabs themselves, and the study team could do the follow-up online. And we used routinely collected data extracts as well from hospitals and from primary care to confirm some of the outcomes. And this is the sort of, shall we say, autobiography of the trial. We started with hydroxychloroquine, and quickly that was stopped because of controversial research, let's say, that was published around hydroxychloroquine. But by that time, we introduced azithromycin, and to be followed by doxycycline. These are antibiotics that were thought to have antiviral and anti-inflammatory properties, which were widely used for community treatment of COVID at that time, and showed that neither of these antibiotics helped in a material way. But we then started inhaled budesonide in December, and that is a commonly used asthma drug, and we used a sort of turbohaler version of it, followed by colchicine, and both signals for futility from doxycycline and azithro, and inhaled budesonide a signal for superiority, and I'll share those results with you in a minute, and colchicine for futility. And at the moment we have favipiravir, which is an antiviral agent, and ivermectin in the trial. And here's our sort of daily randomizations. When we started out at first, we didn't have the swab results of people because swabs weren't available. So we recruited based on the syndrome. As swabbing has become available, the orange bars reflect the people with a positive test, and the recruitment is going up slightly now given the increasing incidence in the UK. These are the general practices, 2,880, that have helped us in some way recruit a patient. That might have just been, for example, helping us with information about eligibility and so forth. But you can see it's a truly UK-wide national trial. And just to give you some, in the third part of my talk, some idea about the evidence generation innovation, the two antibiotics were included in a therapeutic alert from the NHS, which went out to all doctors registered in the NHS, saying that azithromycin and doxycycline were not beneficial, and that included both information from principal and recovery. And just to talk about the budesonide results, we had a interim analysis, which means that all of those patients that had been randomized at that point were included in the analysis, but not all of them were followed up. And we had a signal from the Data Monitoring Safety Committee that there was an evidence of superiority. And we've now done the final analysis where we followed all those people up, and we include in that final analysis 787 with a positive test who got inhaled budesonide, 1,069 who had usual care with a positive test. And the probability that the inhaled budesonide was superior is 99.99%, equating to 2.94. It's a 3-day difference in time taken to recovery. And you can see the survival curves diverging, with inhaled budesonide treated people taking on average 11.8 days to recover, whereas the usual care on average took 14.7 days to recover. And if we look at the hospitalization death, if we take all positive patients in the trial, we find a probability of superiority of about 96%, but that didn't reach our pre-specified threshold for statistical superiority. But in any case, it's an estimated 2% benefit, 9.1% versus 10.9% hospitalized. But if we look in the SARS-CoV-2 positive population compared to controls randomized at exactly the same time, it does reach our pre-specified probability for superiority, statistical superiority. And we find again 2.2% benefit there. The numbers needed to treat about 1 in 50 to prevent a hospitalization. Critically, we find about nearly 50% relative benefit in sustained recovery. Many of us will know that this is a bumpy ride, recovery in SARS-CoV-2 infection, but we find that there's a 10% absolute difference, but 50% relative benefit in those who say they are better and stay better over 28 days. And if we look at a sense of well-being, I'm not going to go through all of this, but the WHO 5 scale, for example, gives us statistically significant benefit day 14 and 28, which is when we measured it. And few people attend their GP or contact health service if they take budesonide. We didn't find any particular subgroup that benefited in a dramatically different way by age, comorbidity, or illness duration, or symptom severity, etc. But if we look at the benefit on hospitalization, there is a statistically significant benefit for those aged over 65. Multiple testing here, of course, but you can see that they all trend in the right direction, these smaller numbers, because it's a rare outcome. And talking about evidence into practice from this type of trial design, based on the interim analysis, the NHS put out another alert saying that they could, on a case-by-case basis, now prescribe inhaled budesonide for people over 50 with the condition. And our final analysis is being peer-reviewed, and they may or may not change that when that update is announced. So at the moment, we have 5,250 randomized. I've mentioned that the colchicine was found, we stopped randomizing to that because there was a signal for futility on recovery. The favipiravir and the ivermectin are still in the trial. And I'll just mention the thank everybody who's been involved, and just summarize by saying that, the three innovations that I think come out of this study are in trial design with platform response adaptive approach. And we use the Bayesian analytic approach, which incorporates much more of the data than a traditional trial design, giving us more power and more people getting a better treatment within trial itself. In terms of trial delivery, we're taking the trial to where the patient can use it. So we have what I call a truly democratic trial, where people's participation is not limited by where they live or where they get their health care. And in enhancing the evidence base, we've shown that the two antibiotics I mentioned don't work for this condition in the absence of other indications. If you use inhaled budesonide, you'll get better about 3 days quicker while you're recovering. It's not just getting better quicker, but while you're recovering, you'll feel less unwell. Your well-being will be enhanced, and you'll often stay recovered. And there'll be a reduced risk of hospitalization. And we've also found that colchicine did not speed recovery, but that is a preliminary finding. So thank you very much indeed. I'll end there. And thanks for the opportunity for sharing this principal trial with you all.
Well, thank you very much, Chris, for this very interesting talk, and especially this new design that you showed us. And we probably, some of you might have questions, but I would like to ask you, use the audience, the question Q&A panel on the right side of your screen. And if you use that, we will collect the questions. And at the end, we will try to answer as many questions as time will give us. But for now, I'd like to thank Chris for this presentation. Very interesting, and especially on the Budesonide trial part of it. And I will give the word to Maria van der Muijsenbergh.
Thank you very much, Patrick, and thank you very much, Chris, for this interesting presentation. Now I'm proud to announce next speaker. He's Yves Jackson, and he will talk about the group of patients that we all know are suffering even more disproportionately from COVID. Yves Jackson works as primary care physician at Geneva University Hospital, and he's also an academic, a researcher. and he specialized in internal medicine, tropical disease and public health, but especially in migrant care. And he is also in charge of a primary health care organization that was dedicated to provide access to underserved populations like undocumented migrants. And among many other things, he is researching the impact of COVID on migrant groups and the influence of social status. And not only is that a fact, he also was one of the founders in 2008 of our WONCA special interest group on migrant care. And I'm very proud he has agreed to talk with us now about COVID and migrants. Please go ahead, Yves.
Thank you very much, Maria. It's for the very kind words. Hello, everybody, and I'm extremely proud and happy to contribute to this wonderful WONCA conference today. And I will talk both as a GP and also as an academic, reflecting observation conducted in clinical practice and also by conducting research with the migrant population here in Switzerland. So first of all, I have nothing to disclose. And let's start by defining who we are talking about. Migrants is a very broad definition of people who moves away from where they used to live and grow as a child. They may be internal migrants, international migrants. They can move temporarily or permanently. So there are many different groups of migrants worldwide. And this talk will touch about mostly migrant workers, international migrant workers, but also a little bit about undocumented migrants, migrants who live abroad without regular residency permits. So overall, the world is moving more and more and faster. So here you see over the last 50 years, the share of the world population being considered as migrants has grown up to 3.5%, which means that more than a quarter of a billion human beings are now migrants. And among this huge number of people, only a very tiny proportion are considered as seekers of refuge. Most of them are just migrant workers going from place to place to find better life through economic and professional development. Countries are very disparate in the way they accept and they host migrants population. You can see here great variation of proportion of migrants within the national population. For instance, Middle East, being Middle East countries with huge share of migrants as compared to other regions of the world. And indeed, at the city level, many cities now have become
Okay, I'm sorry, there was a technical problem. So Yves Jackson will start again with his talk about COVID and migrant populations. And you can still ask questions in the Q&A box. And we read there also that there was a problem. So please indicate there if there's still a problem. Please, Yves, go ahead again.
Thank you very much, Maria. So let's start again. Sorry for the inconvenience. I will talk both as a GP and as an academic, reflecting my observation in clinical practice and by conducting research. So first of all, I want to mention I have no conflict of interest. And let's define who we are talking about. Migrants are people who move away from where they grew up and the usual place of living. They can move within the country or across borders, both temporarily or permanently. And there are many different groups of migrants, and you can see here different names who may be familiar, such as refugees or migrant workers. I will focus my talk on these migrant workers and touch on a little bit about undocumented migrants as well. So the human population is moving more and more across time. In the last 50 years, you can see here the trends with now basically more than 250 million people being considered migrants. And of those, only a tiny minority are considered as refugees or asylum seekers. The vast majority are international migrants, workers, international students, and all types of migrants. Countries have different share of migrant population, and you can see how the geographic disparity between regions, between sub-regions, and across neighboring countries also. Nowadays, some cities have become what we call super diverse. That means that there is no single group of predominant population, but instead an array of origin, identities, entitlements of civil and social rights and practice. And some of these minority cities are those who are represented among the participants of the current conference. And you see Europe is actually the continent with the largest and the most intense movements of internal migration from one country to another as compared to other continents. So as Maria mentioned, migrants were severely affected by COVID-19, and let's have a look at evidence from recent literature. At first, migrants appeared in the headlines of the media early after the beginning of the epidemic, when media reported that a group of population usually away from the radars of public health and medical practice were affected by COVID and had to have trouble getting the usual care. Moreover, we soon saw, like here in Geneva, people starting to queue in the streets because they were lacking essential securities such as access to food. So very early on in 2020, there were signals of something very severe appearing within this migrant population. And indeed, several articles, for instance, in Scandinavian countries, soon started to show that there were a disparity in terms of exposure, suffering, morbidity and mortality in minorities group of population. And the largest study actually was produced in the UK, where this observational study of more than 17 million people could actually compare people from different origins. So when compared to white UK residents, minority group from different origins were compared in terms of proportion of positive testing, hospital admission to ICU unit, and deaths. And actually, what we saw for all of the variables, the minority group were definitely more exposed. And interestingly, regarding mortality, when the crude ratio were usually lower than 1, when adjusted for living conditions, socioeconomic position, age, and other factors, actually all the results were showing an increased severity of COVID-19 infection in minority groups. So there are many explanation factors underlying this observation. First, minority and migrants have differential exposure to the virus at home, in overcrowded accommodation, at work also, where some people had no possibility to protect themselves. There are also differential risks by underlying medical condition, and they could also suffer additional exposure by, for instance, the indirect effect of the lockdown and economical downturn related to the pandemic. And indeed, when we look at the figure, the economic impact worldwide has been huge in 2020 related to COVID-19. An estimated 255 million jobs were lost. And of course, poor, precarious migrant workers were the first and the more intensely exposed to the loss of jobs very early on the pandemic. So these are the words of migrants. We met here in Geneva, Switzerland, in May 2020, when we started to investigate the global impact of COVID on the population. And you see the first lady, a young woman from Brazil, mentioning that my main concern is that I lost my job. I've just been fired. I have only 20% of my budget left. I know I could ask for recognition of my rights. However, this takes time, and I have to pay my rent, my food, my phone. It's always the same story at the end. Either you fight for your right or you eat. Another participant mentioned, I did not seek assistance because I don't want it mentioned in my administrative records. And I mentioned she was worried that she would lose residency permits if she applied for assistance. So we could see emerging a kind of iceberg of insecurity where people queuing in the street for food were actually harboring different other insecurity, all underlined by the loss of employment and very limited economic resources. So this had a very important implication for clinicians, both how to ensure need-based equitable access and delivery of primary care, how to integrate health and non-health intervention to meet the global needs of this population, how to adapt the practice to telemedicine tools that were very quickly implemented, how to cooperate with community resources to boost the impact of medical intervention, how to coordinate, cooperate, and integrate intervention with all other stakeholders, and how to document and advocate for what was needed. And these roles actually are very much aligned with what medical doctors have to do as suggested by CanMed's paradigm. Even more so when we look at what the family doctor definition given by the WONCA proposed: person-centered care, community orientation, comprehensive approach, and holistic management. One of the key issues was proper communication with patients in this time of crisis, and that's what I'm gonna go through in the next few slides. These studies conducted 10 years ago in 16 European countries show that caring for migrants was really associated with many challenges for primary care practitioners. First, the barrier language, then the administrative and financial obstacle, the lack of familiarity with how to navigate the healthcare system, the cultural factors, and also the problem of communication. That's why we designed with colleagues from Lausanne University Hospital this proposition of a comprehensive educational tool and intervention process with migrant population in clinical care, in clinical setting. So first, it is of utmost importance to remove the language barrier by using well-trained professional translator, much more so than friends and relatives. Friends and relatives can be used for emergency situation, but other than that, it should be avoided. Adapting the digital interface can be also a very important tool in emergency, but it's usually a yes/no question, and it's preventing a clinician to go very much in depth. As what we ask from translator is not only to translate, but also to interpret. Look at this cartoon where the clinician is asking about family history, and the patient may have a completely different definition of family. Words are of great importance when we care with underserved group of population. For instance, when we talk about undocumented migrants, using the term illegal might be a real problem. And let's share a little video clip from PICUM that I think highlights this very well.
Être un sans-papier, c'est être en stress tout le temps.
Só porque não tem papel, as pessoas nos tratam inferior.
Ficar sem documento é a coisa mais difícil do mundo.
On est dans une prison, mais en prison ouverte. Pour moi, le mot illégal, il est mal placé par rapport à notre situation. C'est comme un criminel. Et je crois que notre cause, il n'est pas criminel.
C'est quoi le crime qu'il a fait pour que le nom est illégal? Un sans-papier, lui aussi, c'est un être humain. Lui aussi, il a des sentiments.
Quando eu escuto a palavra ilegal, é como se eu estivesse aqui roubando o lugar de alguém, roubando o direito de alguém, o que não é verdade. Porque se está disponível este trabalho, eu não estou aqui roubando, eu estou fazendo aquilo que outro não quer fazer.
Nós somos interditados, somos proibidos de existir. Ficar sem documento é a coisa mais difícil do mundo.
On n'a même pas la possibilité de prendre un verre avec nos camarades, par exemple, et d'entrer un petit peu tard chez nous par peur d'être contrôlé par la police. Ça, c'est une problématique. C'est-à-dire, on ne vit pas notre vie normale comme les autres citoyens.
Un bête contrôle, il peut nous mettre dans l'avion et revenir chez nous.
As pessoas te olham como se você fosse um objeto, verdadeiramente objeto. Podem fazer de você o que quiser.
Dernièrement, je commence vraiment à sentir que je suis moi ici en Europe.
E quando o avião aterrissou, eu já sabia que estava em casa, porque o meu sonho era de estar na Europa e dar uma melhor vida às minhas crianças, aos meus 3 filhos.
Je suis belge, même si je suis un sans-papier, mais ce qui fait la différence entre moi et un citoyen belge, c'est juste le fameux numéro national ou la petite carte.
Eu estou aqui porque eu tenho sonhos.
Eu quero que as pessoas me vejam como uma mãe de família, como uma mulher guerreira que sou, como uma trabalhadora e como uma pessoa igual você, igual qualquer outra.
Les autres. Comme les autres.
Parce qu'il n'y a pas une différence être avec papier ou sans papier, il n'y a rien, parce que on est tous égaux. Il n'y a pas d'illégal.
Okay, so let's get back to the presentation. Okay, culture is another very key issue because it frames how people decide to consult, explain their symptoms, perceive the severity and the meaning of what they are suffering from. It influences the belief about treatments and obviously influences how they see healthcare workers. And therefore, we can explore that by addressing this question in clinical practice with a very simple question that really help to see how people see the world in a way in regard to their health problem. Health literacy is another key issue, and you all know how important is it to investigate the ability of each of our patients to make good decisions by trying to assess the capacities of patient to find his way in a very complex technical world which medicine is today. For instance, here you see the large survey conducted in Europe, more than 8,000 people in 15 countries, and showing that overall nearly half of the European population is displaying problematic or insufficient capacities to manage their own health at different level. So how to manage that? By being very aware of health literacy issue, by anticipating shame, by using plain language, avoiding technical terms, and encouraging question is a very powerful way to interact with patient. And controlling by technique of communication, the good understanding is so important. Finally, socioeconomic position is obviously a key risk factor for morbidity and mortality. You see here this meta-analysis of the mortality of chronic disease, where the odds ratio or the hazard ratio for low SES as compared to other classical risk factors show how important is it on the mortality for our patient. And GP actually tend to overestimate the real socioeconomic situation of the patient. So we have to be very careful how we assess that. And a very simple question to try to investigate if patients are at risk of foregoing healthcare for economic reasons, for instance, is just to ask this simple question: in the last 12 months, have you faced difficulties paying usual expenses? If patients say no, you are safe. You can go on. If you say yes, you have to go deeper in the history taking. So next challenge now regarding minority and refugee and migrant patients is access to vaccine. And we all know that there are huge disparity in Europe in regards to vaccine for migrant population. For instance, some countries have really barriers and no plan to provide regular access. And this is only one of the challenges to be faced, because obviously there is the ongoing recession and in the backstage also the climate change effect that will probably push people more on its way. So caring for migrants is a fascinating issue, because when we do care well for migrants, we do care well for the general population. So I want to thank Maria and all other members of the special interest group on migrant care, mentioning that there will be another session at 5:30 today and a meeting at 6 p.m. on Friday. Thank you very much for your attention.
Thank you very much, Yves, for your impressive lecture and also for the advertisement for our special interest group. And especially, I think the pictures you showed, the movie you showed, nobody is illegal. I saw some comments on that in the Q&A as well. And I hope we all will remember that the core values of general practice of primary care mean that we have to take especially care for the most vulnerable in our patients. There were in the Q&A a few questions for Chris Butler to start with, and we have time for a few, I think. One of the questions, Chris, was whether budesonide should be put into the guidelines. Is it already the evidence that's strong that it could be put into guidelines?
So, thank you very much. Yeah, the peer review of our final analysis is not complete. So, in a sense, we should rely, I guess, on peer-reviewed findings. But these are unusual circumstances, and from the recovery trial in hospital, as soon as they found out that dexamethasone was benefiting patients and saving lives, that was in the public domain, and people started using it and so forth. Now, inhaled budesonide is relatively cheap, safe. There are virtually no side effects from this drug, and I think my own personal view is that if I had this illness again, I would use it.
Okay,
So, in that sense, I'm convinced of the evidence to that extent. Therefore, I think it should be in guidelines.
Thank you very much. I think many patients once ask us, "What would you do, doctor, yourself?" So that's clear answer to that. There's a question for Yves. In the Netherlands, we have seen that many migrant population groups were not very well informed about the policies and the vaccination strategies, and they were very reluctant and didn't trust so much the vaccination program. Do you have, and we see that in where GPs are involved, it's better. Do you have any advice or any ideas about that? What role we as GP could play in stimulating vaccination?
Yeah, that's a very important question and a huge challenge. How to overcome fear and hesitancy in regards to vaccination. I guess GP are at the forefront of direct and indirect intervention. They can directly discuss using a communication tool that we just went through to provide clear, honest information to patients. But what they can also do is use community resources as an indirect way to communicate with population. And that's what we try to promote by having both a clinical and a public health activity, trying to inform underserved group, would it be migrants, homeless, or people living in precarious situation, by engaging with groups that foster trust. For instance, in Geneva, we work with the Red Cross and other organizations, and these organizations have a positive image among a group of migrants. So they are sources of information that people value, and that's, I guess, the good way to do.
Thank you very much. Patrick, do you like to ask a question, Chris?
Because they're also asked, Chris. One is also on Budesonide. Could you throw more light to those and the frequency?
Yes,
and maybe also patients were included within 14 days. And
yes.
Doesn't matter when they were included.
So on average, they've been sick for 5 days by the time they started taking the budesonide. And we looked at people who were included up to 7 days and after 7 days, and found that didn't modify the effect. So as long as people are still sick, it seems to have an effect. And that kind of fits with the potential mechanism of action as an anti-inflammatory. So the budesonide is thought to have an antiviral property in that it stops a virus from getting in the cells and downregulates the receptor. At the same time, it will have a general anti-inflammatory effect as we would expect. So if there's ongoing inflammation in the body, and some of the stuff will be absorbed systemically as well as deposited in the lungs, if you're sick and there's ongoing inflammation, you're going to benefit from this up to 14 days is what we found. And for the dose question, we used 800 micrograms twice a day for 14 days.
Okay. And another one is on your demo. Is on the trial platform you were using, the platform-based. Should that be the future for general practice-based trials?
Well, there are many advantages, Patrick. And you saw there effectively since starting, we started to design the trial midway through March of last year, had our first patient in 2nd of April, 2nd of April. And since that time, we've had 7 agents in the trial. So you can say we've had sort of 7 trials ongoing. So it's very resource intensive, requiring high level of statistical knowledge around trial simulation to get your thresholds for futility and success right. And that's so planning a trial is very, very requiring high level of expertise, and those skills are in short supply. But we've got really 7 trials, if you like, or 7 studies going on more or less at the same time within a year and a half. And that is very challenging because while you're introducing a new medicine, obtaining the drug supply, getting it labeled, getting the approvals, you're analyzing another study, another trial arm. And so, this is very, very demanding on the clinicians, on the recruiters, and on the statisticians and everybody. So it's a brilliant trial design, but very, very challenging to deliver and resource intensive. But with response adaptive randomization, it's not suitable for every condition, because if the outcome takes years to achieve, then it's not a suitable trial design. But in the case like infection, where you're getting getting quite quickly, whether this thing's working or not, then you can use that information to adapt your trial design and drop agents and so forth. So I would say that is definitely a way forward here for primary care research of acute conditions. And in fact, with the principal trial, we're trying to keep it current and sustainable, because although COVID is hopefully going to diminish, flu and RSV are probably going to come back, and there are new agents coming there. So you can see we could have a platform for respiratory infections, and then intervention-specific appendices for subtypes of that. So yes, I think it's got a big future across the board, particularly for the acute conditions.
It's very interesting. Do you, in your trials, also make it look specifically to outcomes from migrant populations or Black and minority ethnic minorities?
We haven't specifically looked at migrant populations, but we have managed to recruit a representative sample of BAME population, as well as a representative sample of deprivation. So people living in socioeconomically disadvantaged communities are well represented in that trial. And particularly, we've only given data up to 28 days, but we're following them up for a year. And we will look at impact of long COVID as well on a subgroup, including deprivation.
Very interesting. I think you both have also made a good plea for more GPs getting involved in research, because this is the only way we can involve all kinds of patients, all our patients, into this very important issues about what is best care. And I'm very glad with the interesting plenary presentations. I'm glad with all the questions that have been asked, and over 200 people who have joined this session. I hope you will continue to care for patients, long COVID, other COVID, for especially with the core values of general practice in mind, providing person-centered, integrated care for everybody in your practice. Thank you very much. Goodbye.
Thank you very much.
Thank you all.
Thank you so much.
Thank you very much.